We're going to now pick up with a very important presentation, the most awaited. Yesterday we were able to hear from the families. It was very enlightening, and I'm extremely grateful to Dr. Schaaf for his time, his availability, his willingness, his good humor, and his disposition to work with all of us. And I do greatly appreciate him very much. And without further ado, we're going to talk about the clinical manifestations of Schaaf-Yang syndrome throughout the lifespan.
Thank you, Ángel. Thank you, Ricardo and Noelia and the entire team for the invitation. I've really been enjoying the time with you and the entire community over the past 2 days. It's been an amazing experience to see the group of Schaaf-Yang families from Spain and Portugal come together here in León, and it's very special for me to be part of it. Noelia mentioned that I'm kind of like the father of Schaaf-Yang syndrome, and in fact I do feel like this is part of my family, so it's wonderful to be here. Today I want to give a brief presentation of the clinical manifestations of Schaaf-Yang syndrome and what we have learned over the last 11 years, and then also provide some brief insight into kind of the molecular mechanisms and the therapeutic avenues that we may be considering moving forward over the next 5, 10, 15, 20 years. This is not a short distance run. This is a marathon that we are running together. But I'm very much committed to running that marathon with you, and I won't be giving up easily. Everything that I and my team know, we have learned from you and your children, and I'm forever grateful that you are always willing to participate in our research studies, like the children are getting blood drawn today to gain further molecular insight into potential biomarkers of Schaaf-Yang syndrome, and also for always filling out questionnaires when we have questions for you. We are currently in touch with approximately 400 individuals and their families worldwide whose children have been identified to carry MAGEL2 mutations. And you can see here that there are some mutations that are common, in particular one mutation that accounts for approximately 30 to 40% of all cases. But then there are many more mutations that are quite unique. Many of them are only identified in single individuals so far. So currently, when I went through the list, we have annotated 183 individual mutations in the MAGEL2 gene that account for respective clinical manifestations. Throughout the talk, I have been providing you with the QR codes of the respective publications from our team and other teams, if you're interested in kind of scanning those and reading up kind of further on that information. So first, I want to give an overview over the clinical features of Schaaf-Yang syndrome and how they evolve over a lifetime. When babies with Schaaf-Yang syndrome are born, they look very much like children with Prader-Willi syndrome, which is a reason for why many, if not most or all, of the children with Schaaf-Yang syndrome have had molecular testing for Prader-Willi syndrome. They have profound neonatal hypotonia, meaning low muscle tone, and they have feeding difficulties, which makes physicians in the newborn units think of Prader-Willi syndrome. But they also have distinguishing features that can be identified that are not commonly seen in Prader-Willi syndrome, in particular the contractures of the joints, especially the small finger joints, but in more severe cases also bigger joints like the elbows and knees can be affected. And this can be a clue to the diagnosis. So when we do have children with hypotonia, feeding difficulties, and contractures, we may think of Schaaf-Yang syndrome. And in fact, there's a number of cases worldwide that did not have exome sequencing or genome sequencing, but where the physicians in the newborn unit remembered some of our publications and thought of Schaaf-Yang syndrome and ordered specifically sequencing only of the MAGEL2 gene. These first months of life oftentimes are very difficult because the children are very sick and they spend a lot of time in the newborn intensive care units. This is particularly the time when families really worry about the well-being and the life of their children, and they worry whether their children may or may not make it out of the newborn unit. In particular, the respiratory symptoms are rather severe or can be very severe, in part due to central and obstructive apnea. Many children need to be intubated, to be put on ventilators, and approximately 1/4 of the children end up needing a tracheostomy because they need long-term respiratory care. Here you can see some of the hands of the children with Schaaf-Yang syndrome. Some of those hands are actually the hands of children that are here at the meeting. And they're quite unique, not only because of the contractures, but also because the tapering shape of the fingers. Sometimes the contractures can be so severe that the children do need surgery, but in many cases they do not need surgery. It's just a reflection of the babies not moving their hands enough while they're in utero, and with physical therapy and stretching and sometimes also kind of splints that are put on the hands, the situation gets better over time and many children do achieve a full range of motion. As the children get older, we appreciate that they delayed in reaching their developmental milestones, and it's a global developmental delay where they do take longer not only to sit and crawl and walk, but it also affects speech, and it takes longer for them to acquire words and to start speaking. The low muscle tone does continue, and a third of the children also develop seizures, which typically are relatively easy to control with a few medications, and we're not aware of many cases where there's intractable epilepsy that has tremendous impacts, but it's something to watch out for. As the kids get older, we also appreciate not only the language impairment, but also the impairment of social interaction. And many children are diagnosed with autism spectrum disorder. This is also a distinguishing feature because the prevalence of autism spectrum disorder is much higher in Schaaf-Yang syndrome compared to Prader-Willi syndrome. The facial features and the shape of the head can be quite distinct, and you realize that when you look at your children because some of them actually look like siblings to one another because they do have a fairly distinct appearance. And sometimes we see also pictures on Facebook or on social media, and it almost seems like it's a picture of what could be a sibling to your own child. Ocular anomalies are relatively frequent, in part related to the muscular hypotonia causing a high prevalence of strabismus. Skeletal features are present, again, in part due to hypotonia, but there are also intrinsic mechanisms at the level of the bone that are impacted by MAGEL2 dysfunction. So a lot of children with Schaaf-Yang syndrome have scoliosis, kyphosis. Some of them do require surgery because it can become quite severe, and once it starts impacting their ability to breathe, it may be necessary to do a corrective surgery. Because of the intrinsic function of MAGEL2 at the level of the bone, with the cells that kind of rebuild bone, children with Schaaf-Yang syndrome also tend to have low bone mineral density, kind of similar to osteoporosis. This is something to look out for, and we do recommend at the latest when children are 5-6 years old to have a study to have bone mineral density evaluated, because if that is low, it can be a risk for developing fractures due to insignificant trauma, and it can be supported by supplying vitamin D, calcium, and if more severe, we can also give bisphosphonates, which is a class of medications that's also given to women, for example, with osteoporosis. Sleep apnea is something that oftentimes gets better over time, but needs to be considered and needs to be evaluated. We realize that there is increased not only morbidity but also increased mortality for children with Schaaf-Yang syndrome, and I feel that apnea is one of the main causes for potential lethality in the children, because when it's not recognized, children can actually, unfortunately, die in their sleep. And we've had a few cases where the family woke up in the morning and their child with Schaaf-Yang syndrome was not alive anymore because he or she stopped breathing during sleep. So this is certainly something to have each child with Schaaf-Yang syndrome evaluated for. If it's not present, then that's wonderful and, gives relief to the family. But if there's significant apnea, it does need to be monitored with like a pulse oximeter during sleep, and or also be supported with BiPAP or CPAP machines. Gastrointestinal issues can be present, especially constipation is an issue that sometimes needs attention, also not only through diet, but also can require medication. And then because of the important function of MAGEL2 in the hypothalamus, many other bodily functions can also be affected, such as temperature instability or the ability to perceive pain. We've already talked quite a bit yesterday about growth hormone. So this is in part something that we learned from the Prader-Willi community, because a lot of research has been done into growth hormone deficiency in Prader-Willi, and recombinant growth hormone has been approved as a treatment for Prader-Willi syndrome for many years, and really has changed the trajectory and the outcomes of the respective individuals. So when we learned about Schaaf-Yang syndrome in an early study, we also looked at the hormonal status of the children with Schaaf-Yang syndrome and collected evidence suggesting that children with Schaaf-Yang syndrome may also have growth hormone deficiency. And so more and more children with Schaaf-Yang syndrome have been started on recombinant growth hormone, and we've seen many beneficial effects. We use this in an off-label approach because it's not a formally approved medication for the indication of Schaaf-Yang syndrome. But you do see one of the patients from the United States. This is Trinity Hanners from Kansas. She was diagnosed at I think beyond the age of 10 years. And she was started on recombinant growth hormone, I think, when she was 13 or 14 years. And between those two pictures, there's only 4 months time that has passed. And you see the enormous effect that it has on the body composition. It's not only important in order to gain longitudinal growth, but it also remodels the composition of the body, shifting from fat mass to lean muscle mass. And this not only decreases body adiposity, but also builds muscle and improves stature, strength, stamina, and endurance. So Trinity is a child that was not able to walk longer distances, let alone ride her bicycle. And with the start of recombinant growth hormone, she was able to achieve that. And with that, the quality of life for her and the entire family has dramatically improved. Now, we wanted to talk about the manifestations across a lifespan. And so it's really important to look at the adults with Schaaf-Yang syndrome. The vast majority of cases that we aware of, and also the vast majority of cases that we have in our databases are children, and that is in the nature of neurodevelopmental disorders, and also us having exome and genome sequencing available in clinical practice only for the past 5 to 10 years. So the vast majority of cases diagnosed today are young children. Older adults are not frequently diagnosed, unfortunately. But we're in touch with a number of adults, and I went through the list yesterday and I realized there's a significant number now of individuals in their 20s and 30s, and there's individuals up to the age of 51. 51 is the oldest individual right now that we are aware of with a typical truncating mutation in MAGEL2. And then there's other individuals with missense variants in MAGEL2 who share features with Schaaf-Yang syndrome that are even older. And what can we learn from them? Like, how does the condition change over time? So when we first reported cases of MAGEL2 mutations, we felt that one of the distinguishing features between Prader-Willi and Schaaf-Yang was the absence of hyperphagia and severe obesity. Now, that concept may not hold true entirely looking at the older individuals with Schaaf-Yang syndrome, because when we ask families, especially parents of children who are at adolescent age or older age, it seems that the feeling of satiety, so the feeling of fullness when you've eaten a plate full of food, does not to be fully present among individuals with Schaaf-Yang syndrome. And with that, they do tend to overeat, not as severely as we see in Prader-Willi syndrome, but they can eat big amounts of food. And with that, also in the older individuals, the prevalence of obesity does increase. So it does seem that many of the adult individuals with Schaaf-Yang syndrome do tend to be overweight, and I think it's important for us to realize, because we can keep an eye on this very early and support our children when they're teenagers and young adults to have a healthy lifestyle, a healthy diet, an exercise program in order to prevent the secondary effects of obesity and metabolic syndrome. Also, the behavioral challenges do seem to change somewhat as the kids and the adults get older. Anxiety is something that is highly prevalent among older individuals with Schaaf-Yang syndrome, and that is something that we can probably help also through like psychological intervention, therapies, and if needed, medications. Abnormal sleep cycle does persist, so I didn't mention this for the children, but children and adults and also animal models of Schaaf-Yang syndrome do have altered circadian rhythm, and it's difficult for them to have good sleep hygiene and like a regular sleeping pattern. And that is, made worse by the persistence of apnea, and adults also when they overweight, they may need additional support through CPAP or BiPAP machines to support their breathing and their oxygenation during the night. Chronic constipation does persist as the individuals get older. And in this publication, for which I've shown you the QR code, we show some images of individuals with Schaaf-Yang syndrome kind of across the lifespan, and you can see in each column the pictures of one individual, and you get to appreciate how the face and also some of the bodily features kind of persist and change over time. Generally speaking, and I think part of this is a good message, especially for the families who have young children with Schaaf-Yang syndrome, I'm convinced that the most challenging time is really in the neonatal and the early infantile period. That's when the children are medically most unstable. As they get older, they become medically more manageable, and they spend less and less time in the hospital, much less time in the intensive care units, and they do grow up to be fairly healthy individuals. But the challenges do change as we evaluated in this study that was conducted with the support of the Foundation of Prader-Willi syndrome. So not only obesity and overeating and anxiety and behavioral issues do kind of increase as they get older. But obviously the families and the affected individuals also worry more about what's going to happen when they're grown up. Can they live independently? What will happen when the parents are not there to take care of them anymore? Trying to kind of put it into one diagram, looking at the overlap and also the differences of Prader-Willi and Schaaf-Yang. There are clear differences that are particularly present kind of during the childhood time, when children with Prader-Willi syndrome already have severe hyperphagia and develop obesity. Whereas, on the other hand, children with Schaaf-Yang syndrome have contractures and a higher prevalence of autism spectrum disorder. Also, as we've mentioned before, sometimes children with Schaaf-Yang syndrome have a level of cognitive impairment that's actually more severe than what we see in Prader-Willi syndrome. And we're now getting the first hints from our molecular studies why that could be. So what is our current understanding of the underlying molecular mechanisms? Françoise actually was kind enough to also show this graph that Tim Schubert, one of the students who works with me, has kind of put together and was published in a review article on MAGEL2 and Schaaf-Yang syndrome that was published earlier this year. He shows beautifully how Schaaf-Yang syndrome really affects the whole body. We do believe that most of the features that we appreciate come from this dysfunction in the central nervous system, but through the effects on like nerve and muscle and the hormonal system, we do see the clinical manifestations of Schaaf-Yang syndrome in the entire body. We're also starting to gain some molecular insight into what a dysfunctional MAGEL2 protein does in the cell and how that affects molecular pathways and how that can affect other proteins and genes as well. And some really important work comes from Rosa's group, and I'm sure she will go deeper into that, really showing that it's not just about the lack of functional MAGEL2, but the truncated version of MAGEL2 also has new effects inside the cell. So they have shown very beautifully in overexpression cellular models that truncated MAGEL2 protein is present more in the nucleus than what it's supposed to be in a healthy cell. So the distribution of the MAGEL2 protein shifts within the cell. And so we believe that this is important also for our therapeutic strategies, because it may not only be important to bring healthy MAGEL2 into the cell, but we also think that we need to get rid of the mutated and toxic version of MAGEL2. This is a fairly recent publication by Alexander Hüttenhofer and his group from Austria. Alexander has worked on the snow RNAs in the Prader-Willi locus for many years, but more recently, because he got to know a child with Schaaf-Yang syndrome in Innsbruck in Austria, also started a line of research looking into MAGEL2. And he and his team showed some important interactions of the MAGEL2 protein with other proteins that are known to also cause neurological or neurodevelopmental disorders. For example, the FMR1 protein that is, when it's mutated and not expressed, a cause for Fragile X syndrome, which is a neurodevelopmental disorder that manifests intellectual disability and autism and other features. And also an interaction with the SMN1 protein, which, when it's lacking, is a cause for spinal muscular atrophy, which is a condition that goes along with very profound muscular hypotonia. And so they are proposing that it's important to see MAGEL2 in the context of all its interactions, and that some of those interactions may be accountable for some of the features that we see in the children with Schaaf-Yang syndrome. This molecular understanding is critically important for us in order to develop therapeutic strategies. And while from a daily perspective, everything in research is going too slowly, and we are impatient with the little progress that we make. When we take a step back, it's actually amazing to see how far we've come just over the last 11 years in our understanding of Schaaf-Yang syndrome and also some of the related molecular mechanisms. In part due to the work of Françoise Muscatelli, whose talk we've just heard, who has studied and investigated MAGEL2 long before Schaaf-Yang syndrome was even known. And so we could resort back to some of her findings and animal models that were already in existence. So we talked about growth hormone quite a bit. We also talked with Françoise about the potential for oxytocin treatment. And then there are other strategies. And one is to bring in healthy MAGEL2 into the cells, which could be done by gene therapy, but could also be done by unsilencing the maternal copy of the MAGEL2 gene, which is present in each and every cell of your children's body. And if we were able to release the imprint, it could lead to the production of normal MAGEL2 protein. But as I mentioned before, I do believe that we also need to get rid of the mutated version of MAGEL2. And this is one strategy that we're taking in the laboratory now through antisense oligonucleotides. These are specific small molecules that are designed to bind to the mutated version of MAGEL2 and titrate it away to get rid of the mutated copy of MAGEL2 RNA in order to decrease the toxic effects that the protein then may be able to develop. And antisense oligonucleotides are a new therapeutic strategy in several neurodevelopmental disorders and are already in practice for some of them. So before I close, I just want to show you some of the, which I think, exciting new developments and what's going on in our laboratory right now. So we're working on these therapeutic strategies with the AESYS, the antisense oligonucleotides. A part of my team is also developing a clinical severity score for Schaaf-Yang syndrome, and we are close to sharing that information with the scientific, medical, and your community, which can be helpful to determine where your child stands on the spectrum of severity, but will also help us better understand the correlation between certain genetic mutations and the clinical severity that they cause. The rat model for Schaaf-Yang syndrome is relatively new, and it's really the first and only model that has good construct validity because it's the first and only animal model that we have on hand which carries a mutation in MAGEL2, which is a truncating mutation, so similar to what your children actually have. And I do believe that this rat model will be incredibly valuable for the research that we do, not only in understanding the disease, but also in testing out therapeutic strategies. And then our newest team member, I also wanted to present. Her name is Rachel Gilmore. She is a postdoc who's funded by the Foundation for Prader-Willi Research for 3 years, who's moved from the United States to our lab in Heidelberg, and who will only and exclusively work on MAGEL2, will work on establishing a new antibody for MAGEL2, will work on establishing functional assays to test the consequences of MAGEL2 mutation, and so much more. So with that, I'll close. I'll say a brief thank you to all the collaborators and my teams during my time in Houston, and now also during my time in Heidelberg, which hopefully will go on much longer and we'll stay connected. And I think there are exciting times ahead of us, and I look forward to everything that we can achieve together. And I do not want to close without kind of mentioning what Hannah Hanners, the mother of Trinity, whose pictures I showed, said at one of the very first Schaaf-Yang meetings in the United States. She said, "I'm no longer alone. I have a tribe." And I think this is really what we've been experiencing also over the past 2 days. Rare diseases can make you feel incredibly lonely and desperate because there's nobody who understands what you're going through. There are no medical experts who understand what you really need. But coming together as a community is so powerful because we meet these other families who are on the same path, who are experiencing the same challenges that we are experiencing, and who are willing to run that marathon together with us. And then also the dedicated researchers from Spain and other countries who are also willing to run that marathon with you. So let's look forward to what we can achieve together in the next years. Thank you.
Spanish. Gracias, Dr. Schaaf.
Thank you, Dr. Schaaf. I found that extremely interesting. Are there any questions? Do we have any questions? I certainly have a couple of questions, Dr. Schaaf. What you said is that the truncated protein does not function adequately, and what we've seen on the slides is that it is in the nucleus. And so is that internalization in the nucleus, which is theoretically not what occurs physiologically, we've seen that this can cause genes to be triggered or to be inhibited, and this is a consequence of the collateral effects of the truncated protein. So could we perhaps work on therapies that might compensate or offset this increase in the expression or this inhibition in the expression of these genes?
Yes, so I would think that Rosa can probably also kind of go into that work, because it was really her group who first showed through overexpression studies that this mislocalization is the case. I think, typically MAGEL2, it kind of shuttles between the nucleus and the cytoplasm, but the distribution and the amount of how much is in the cytoplasm and how much is in the nucleus is shifted. We don't know exactly what those consequences are on a molecular level. We are currently doing a lot of research on induced pluripotent stem cells and kind of induced neurons from Schaaf-Yang cases, and evaluate them both by transcriptomic and proteomic analyses. And some of the differences on a molecular level, we are appreciating and will be investigating further. I think we're still in the early days in order to understand what the multitude of functions of MAGEL2 really are. There are many more functions on the graph that I have not gone into detail. Like one important function is the participation in processes of ubiquitination, which is like putting marks onto proteins and removing marks from proteins that are important for kind of molecular assembly within the cell, but also the recycling or the degradation of proteins within the cell. So there's so much more to be done, and I feel like, I'm 46 now, so if all goes well, I'll have another 20 years or so in the field. It will not get boring. Yeah.
Only 46, good. You're young. This one I will make it in English because it's a special word. Is it the possibility to improve the work of the chaperones? Let's see, for example, the Hitchcock protein 70 or 90, in order to balance this truncated protein, in order to get rid, as you said, with ubiquitin.
Yes, like Hitchcock by itself is an interesting concept because it also relates to the cell's ability to adapt to stress. Like heat can be one stress kind of affecting the cell, and MAGEL2 may actually play a role in that as well. I personally feel that really a more direct way to kind of tackle the aspects that relate to kind of the mislocalization and the unwanted effects of MAGEL2 would be to treat it at the root of the cause and really kind of get rid of that transcript that originates from the truncated mutation. I could see how in the long term, children with Schaaf-Yang syndrome could be treated with two approaches, one being to get rid of the mutated version of the gene and then also either releasing the imprint from the maternal copy, which would be the ideal approach, I think, or a gene therapeutic approach. But you have to be careful also for many neurodevelopmental disorders. We know that there's a concept of dosage sensitivity. So not having enough is not good, but having too much is also not good. It needs to be just right. So I personally believe the best way to approach would be to just get rid of all the mutated copy and then release the imprint from the maternal copy, and that would probably be the best approach. So that's what we're working towards in parallel. Like we are currently focusing on the antisense oligonucleotides, and then other groups in Australia and in the United States are working on the release of imprinting.
Gracias. ¿Alguna pregunta?
Thank you. Any more questions? Thank you so much, Dr. Schaaf.